Next will be Dr. Monju Patel, who'll be talking about MRI before prostate biopsy.
Thank you for having me. I think one of the most important things when reading these MR prostates is to have consistency. And that's one of the great things I think that we do here. It's Dr. North and myself that's primarily reading these prostates. The reason why is there's a lot of ambiguity to the way you can interpret these MRs, which I'll kind of show you a little bit about. I do not have any disclosures. The two big professional practice gaps I have, we're starting to get in an age of medicine. We're trying to fit everything neatly into boxes. We have all kind of I-RADS now, as I call them, the TI-RADS, lung RADS, PI-RADS. And sometimes it's not easy to fit it in a box. I would say my biggest issue with the PI-RADS is trying to differentiate a PI-RADS 3 versus 4. Sometimes it's difficult to fit in a box exactly. And even within the PI-RADS 3, I hope we can stratify those as low risk and high risk, because some of them I'm more leaning towards the PI-RADS 2, and the others I'm leaning more towards the PI-RADS 4. And then the other thing I've noticed actually in the last year or so is what to do with these post-treatment images that we get with MRI. And when we're following up patients with clinically known significant cancer, does it really make sense to use PI-RADS? So some of the things I'm going to go over today is review some the optimal MR imaging of a prostate gland, some of the PI-RADS priorities as it relates to imaging, some detection pitfalls, and special scenarios when it comes to imaging. So when it comes to MR imaging, there's three essential components. You have to have a high resolution T2, and that's why we have to have it done on the 3 Tesla magnet. I think it's pretty much readily available everywhere you go now in this country. The other thing is you have to have adequate diffusion imaging, and you have to have a good dynamic post-contrast set of images as well. We don't really use endorectal coils. I actually don't know of any patient in the last several years that has had an endorectal coil to look at the prostate. And for example, this is a prostate that we did on a 1.5T. It was on an inpatient, but you can see that the resolution of it's terrible. So that's why you really need to have it on a 3T magnet. The two biggest limitations I would say when it relates to imaging, one of the biggest, and it's nothing we can really do anything about, is rectal gas. Unfortunately, it causes a lot of artifact kind of right in the area where we're trying to look at to see if there's a restricted diffusion signal. I can tell you from my experience, if a patient has a hip implant, it's most likely going to make the diffusion images and the post-contrast images non-diagnostic. Now, we can definitely get useful information just from the T2 images, but you may want to spare them from getting at least the contrast images. So here's an example of a PI-RADS 3. So you can see that in the right aspect of the prostate gland, there's this kind of wedge-shaped area of abnormal T2 signal. Unfortunately, on the diffusion images, there's a little bit of restricted diffusion. So technically, by the PI-RADS criteria, this would meet to be a PI-RADS 3, but honestly, I would put this more leanings towards a PI-RADS 2. And the reason why it's important is because the current guidelines actually recommend targeted biopsy of this, but if you ask me, I would suspect that this is going to be benign. We actually have another example here, and this patient had follow-up. So you can see right there that there is some abnormal signal in the left aspect of the peripheral zone. The diffusion images, unfortunately, were non-diagnostic because of the rectal gas, and on the post-contrast images, we really didn't get any positive enhancement. So based on that criteria, this fit in a PI-RADS 3. This patient, fortunately, got follow-up 2 years later, and just incidentally, and you can see that area in the left part of the peripheral zone is gone, and now we have a new area in the right PZ, which is suspicious. Or sorry, not suspicious, but probably an area of prostatitis. Moving on, so in the peripheral zone, the things that we're looking for are things that are T2 dark and nodular. I would say those are probably the two biggest things I'm looking at, and I try not to bias myself with the post-contrast images and diffusion images. First, I'll look at the T2 images. So if I have a nodule like this, I'm already pretty suspicious. And then if you go to the diffusion images, you can clearly see that there's marked restricted diffusion. One of the first questions I get from the residents when they're interpreting this is, how do you know that it's marked versus mild versus not restricting? And really the only answer I can give them is experience, because there's no way to quantify or get any type of measurement, kind of like in CT where we measure enhancement and things like that. We can't really quantify the degree of restricted diffusion. It's kind of a judgment call. And the same thing with the positive contrast enhancement. So essentially the things I'm looking for is very early enhancement, enhancement that's greater than the remaining peripheral zone, or enhancement and washout. So here's an example of early enhancement there in that same nodule. So when you get it all together, to me there's no question that this is a PI-RADS 4 lesion. Here's another example, and this one's not quite as nodular, but because the T2 dark signal is there, that already makes me pretty suspicious. And then when you go to the contrast images, you can clearly see that there's enhancement, and on the ADC there's low signal. So for me, there'd be no question that this is a PI-RADS 4. And here's a smaller nodule again, and I call these the triple match. Whenever I get this, I'm not going to hedge about what to call it. To me, there's no question. This is an example of a biopsy proven, which came back as Gleason 4+3. One of my other issues with PI-RADS is the difference between 4 and 5. The only criteria differentiating the two is size. So, basically you're saying if it's 1.4 centimeters, it's only high suspicion, but if it's 1.6, now it's very high. And I don't really agree with that, but in this case where you can clearly see that there's abnormal tumor all throughout the left part of the prostate gland, it's certainly greater than 1.5, probably closer to 2 centimeters in size. And if I localize it on the T2 images, that's probably the region of interest I would draw on the DynaCAD. The other thing to remember about PI-RADS 4, it's not, so while I mentioned the size, there's one other thing, and that's if we can see some nodularity or indistinctness of the prostate capsule. So here's an example of a case, on first glance, it's not over 1.5 centimeters, so you would think it's just a PI-RADS 4 lesion, but on the post-contrast images, you can see that there's a little nodular area, and that's, certainly very concerning because it's right next to a neurovascular bundle, so this was actually called a PI-RADS 5. The transition zone, I'll say, is actually very tough to evaluate. When I'm teaching my residents this, I encourage a lot of patience because it's really hard to differentiate tumor, but I think where we can be useful as radiologists to you all is definitely for all the anterior tumors, which would probably not be reached by routine biopsy. So here's an example along the right anterior transition zone, and you can see that there's abnormal T2 signal, which is kind of different from the rest of the BPH in the transition zone, and it clearly demonstrates restricted diffusion signal. Here's another example, and this one's in the left anterior transition zone. You can see that there's abnormal T2 signal to begin with, and then the post-contrast and the diffusion just kind of confirms that there's likely tumor here. Here's an example of a larger tumor, more extensive. You can see along the right aspect of the transition zone, mostly anteriorly, but also extending mid and maybe just into the posterior. And you can clearly see that there's early arterial enhancement, restricted diffusion, and then the reason why I like this case is whenever you try to decide on whether there's positive enhancement or not, the one other thing you can use is a DynaCAD color fusion, and then the red signifies that this is the area of early enhancement with gradual washout, so that makes it very suspicious. As far as, I think the one other area where we can be helpful is for extraprostatic extension. So MRI will have a high specificity, but the sensitivity is not that great, so we can't always say that there's not extraprostatic extension. But here's an example where you can clearly see that in the right seminal vesicle, there's abnormal T2 dark signal compared to the normal left seminal vesicle. And then on the post-contrast images and the diffusion, you can clearly see that there's tumor burden in this region. Here's an example of bladder invasion. So you can see that there's extensive tumor along the right aspect of the prostate gland. And then if you go to the sagittal T2, you can see that there's kind of this abnormal T2 signal along the posterior bladder, and then on the post-contrast images, the posterior bladder wall was enhancing, so this is likely bladder wall invasion. The one other thing that's really important with the MR imaging is you need to have one sequence that covers the entire pelvis. So that's super important, and the reason why is you don't want to miss any lymph node mets. So this example with extensive prostate cancer, and then you can see the nodal mets here. So what we do here is on our T1, we make sure that it goes at least to the aortic bifurcation. So you don't need all the images to cover the pelvis, but you probably should have at least one. So some of the detection pitfalls, I'll say the two biggest ones, one set is related to the normal anatomy, and then the other one is when there's diffuse disease. Sometimes it's difficult to differentiate between prostatitis and infiltrative carcinoma. So here's an example of anterior fibromuscular stroma. So the top right image, you can see it's kind of uniform and symmetric. It's a little bit thicker of a anterior fibromuscular stroma, but that one's still pretty obviously just that. And then the example below, it's a little asymmetric, but the key is on the B images, there's no increased signal, so this was just called asymmetric anterior fibromuscular stroma. And here's an example of something that's not anterior fibromuscular stroma. So you can see it's kind of a lot thicker than it should be, has irregular margins, and then on the B2000s, there's clearly high signal with some, it's subtle, but there's some early enhancement. So this was anterior tumor. We don't see the central zone a lot, and we usually don't even comment about it on our reports, but every now and then we'll get a nice example. Oops, sorry. So going back, you can see that there's symmetric T2 dark signal here and here. And then if you localize that to the B images and the contrast enhancement, there's no suspicious signal. And here's an example of a central zone malignancy, or a malignancy in the region of the central zone. So on first glance, it really doesn't look all that suspicious. But when I move on to the post-contrast and the diffusion, you can clearly see that there's abnormal signal there. So it can be a detection pitfall area. Again, prostatitis and diffuse carcinoma, these can be quite difficult, and that's why having the biopsy information, if there were any previous biopsies, are super helpful. So here on the example on the left is diffuse prostatitis. The peripheral zone is completely dark, but you can still kind of see some differentiation between the PZ and the TZ. On the right image, this is a kind of more typical example of prostatitis that we see. And it's more kind of intermediate patchy signal compared to the dark signal on the left. Focal prostatitis, this is a little bit more easier to identify. You can see that there's some atrophy along that right PZ. There's intermediate signal, and then there's no abnormal signal on the diffusion images. And so here's an example going back to the prostatitis. This is an example of diffuse infiltrative carcinoma. And the reason why this is difficult is because the diffusion signal really relies on comparing it to the normal gland. But when the whole gland has abnormal signal, it's really hard to differentiate. So this was a patient that had diffuse tumor that was up to Gleason 5+4, sorry, it should be 9. And just to show you, this is that the example in the middle is a prostatitis, and the one on the left is diffuse infiltrative cancer. So that's why it's important to have the path information when we're reading these. Hemorrhagic exclusion sign, that's something that we see every now and then. It's a nice imaging finding. So the area of tumor will not demonstrate hemorrhage post-biopsy. The positive predictive values 50% alone, but when you use it with the diffusion images and the post-contrast, it can get pretty high. Some other special scenarios when we image patients is especially after a TURP, when the pathology comes back as positive. So this was a suspicious focus along the right aspect of the terp margin, and you can see that there's clearly abnormal T2 signal. There's low signal in the ADC, and then there's abnormal enhancement. So this was suspicious for tumor. The other thing to point out on this is you know, wherever you're getting your MRIs interpreted, you want to make sure that they have adequate diffusion images. So you have to have the right set of B levels. And on the B1000s, the tumor doesn't really show up as well, but when you go to 1600s, you can clearly see the tumor. I usually think the optimal window is about 1400 to 2000. The other thing we're starting to see a lot now is active surveillance. So this is a patient that had a nodule in the right PZ. Initial biopsy was Gleason 3+3. A year later, in 2017, it was rebiopsied. It looked like it got a millimeter or so bigger. It came back as Gleason 3+4. The other thing that we see a lot is a post-cryoablation or some type of post-treatment. So here's an example of a tumor right here in the right PZ, and it underwent cryoablation, and the follow-up imaging demonstrated no suspicious tumor. And it was actually biopsied as well, and it showed no suspicious findings. Then the last thing, local recurrent detection. So MR has a high specificity, but the sensitivity is not good at all. You know, obviously the other alternative would be an Axumin scan. This is an example right here on the top right, where you can see some recurrence in the surgical bed. On the images below, you can see that there's abnormal enhancement and T2 signal in the resection bed, and so that was suspicious for tumor. The one most important thing as far as imaging goes for these, the diffusion images really don't matter as much. It's really the post-contrast imaging. So if you have a bad injection or a poor injection, you really want to repeat that because it's essential for diagnosing recurrence. This is a case that we had, I think about a year or so ago. And in the prostatectomy bed, there was this T2 hypointense nodule, and it showed very early enhancement. So this was very suspicious for local tumor recurrence. And then the last example I have here is this case which I thought was obviously a PI-RADS 4. I've been doing this for several years now, and to me there was no question. So you can see that in the right PZ, there's a T2 nodule. It's clearly showing restricted diffusion signal and some early enhancement. And so when the biopsy came back as negative, I was like, there's no way that's possible. But then we ended up getting follow-up imaging, and you can see that it now has a T2 hypointense rim. So what I actually think it was a BPH nodule protruding into the peripheral zone, and that's why it came back as benign. So that's the first time I've seen that, but you know, we're still kind of in the beginning stages of interpreting these, so I'm sure we're going to find a lot of scenarios like this where we're not absolutely correct about what's going on. So in conclusion, MR is a useful tool for detection, recurrence. You know, PI-RADS is not a perfect system, but I do think it's great because it, you know, gives us uniform communication. I think most radiologists and urologists agree that it's a fairly good system, but obviously there's area for improvement. And you know, I know while the data only supports getting MRI in a negative patient with negative biopsy that has high risk, you know, we're starting to see, especially over the last couple of years, other scenarios where we're using MRI, and so you know, only time will tell whether we're actually doing a benefit for the patients. But you know, I think most of our urologists here really like to use MR, you know, just kind of as an adjunct tool. And obviously, you have to give considerations to, you know, patients' background, whether they're able to afford that, since they're fairly expensive tests. And then the last thing, active surveillance issues. You know, I know you guys know about this. From a radiologic perspective, I think the biggest thing is there's really not been any papers discussing what signifies progression. You know, obviously we have size, or if there's any new nodal or extraprostatic disease, but we don't have really a way of quantifying these tumors. You know, one thought would be measuring the ADC signal to see how much it's restricting. or maybe getting the kinetic enhancement of the tumor to see if it's changed. But outside of size, we really don't have anything else. And that's it.